Okay, welcome to Pathology of the Lower Gastrointestinal System. We're going to start this presentation on slide 5 with small bowel disorders. The first disorder we're going to discuss is called malabsorptive syndrome. And another word for this is called celiac disease or celiac sprue. And this disease is characterized by the GI tract being unable to process and absorb nutrients, hence the name malabsorptive. Oftentimes these patients may have lactose or sucrose sensitivities, and they actually develop deficiency syndromes because they're not absorbing vitamins and electrolytes and iron and calcium and the basic nutrients that is normally absorbed through the small intestine. So they develop deficiency syndromes. Now, during a small bowel evaluation, the lining of the small intestine or the mucosa may appear thickened because it's constantly irritated. So you can see here you just have this thickened and irritated appearance in the small intestine. So what I want you to know is that celiac disease or celiac sprue is another name for malabsorptive syndrome, where the GI tract is unable to absorb nutrients. Okay? Let's look at Crohn's disease. Now, Crohn's disease is also called regional enteritis, and we talked about this last semester. It's a chronic inflammation of the intestine, and it's really a form of an inflammatory bowel disease, and we don't really know what causes it, and it can affect any part of the GI tract, but it normally involves the end of the ileum or the terminal ileum. Now, this Crohn's disease is going to lead to scarring and thickening of the bowel wall. And oftentimes that scarring and thickening leads to this cobblestone appearance. Okay. So again, chronic inflammation, the intestine is chronically irritated, and so it becomes kind of scarred and thickened as a result. Now, in advanced cases of Crohn's disease, you will have narrowing of the intestinal wall because of all that chronic inflammation. All right, regional enteritis or Crohn's disease can also lead to intestinal obstructions, a fistula, which remember is a hole where it shouldn't be, or even an abscess or infection. And, even after treatment, unfortunately, this disease has a high rate of reoccurrence. All right. Let's talk about an ileus. Again, this should be a review from first semester. We often see ileus in abdominal series when we're doing plain x-rays, a flat and an upright. Remember, we're looking for air fluid levels. Now, remember, so let's back up. An ileus is going to be a type of bowel obstruction, right? Remember, there are two types of bowel obstructions. There's mechanical, which means there's an actual physical blockage, or there's an adynamic bowel obstruction, meaning there's no peristalsis occurring. Now, what we look for in x-ray is we look for any dilated loops of bowel or any air fluid levels. Okay? All right. So I'd like you to just remember that an ileus is a bowel obstruction, and it's typically due to a lack of peristalsis. Okay? All right. So I think this slide is a little misleading. An ileus generally refers to an adynamic bowel obstruction. A mechanical bowel obstruction is something is physically blocking the intestine, and usually that's where you'll see the presence of the air fluid levels. Here we have a dilation. So when you think of ileus, just think of peristalsis has slowed or stopped in the intestine, and so everything just kind of stops and nothing progresses or becomes digested. All right, let's switch gears and talk about large intestinal disorders. And this is kind of an interesting one to me. Hirschsprung's disease. Hirschsprung's disease is a lack of nerve cells in the rectum, and so you're born with Hirschsprung's disease. And this occurs in approximately 1 out of every 5,000 births, and it's more common in males. Signs and symptoms include chronic constipation and a distended abdomen, and this often results in a megacolon. Remember, or just think about this for a second, if you don't have any nerve cells in your rectum, you never know, like your body never knows when it needs to evacuate stool. So you're chronically constipated, which means that your colon becomes distended and filled with stool, and you never know that you have to go to the bathroom because there isn't those nerve cells to tell you that it's time to go. Here's a picture of Hirschsprung's. And again, remember, this is congenital, so you're born with this. And generally, we need surgery to help repair with Hirschsprung's disease, but it is pretty rare, only occurring in 1 out of every 5 to 10,000 births. So Hirschsprung's disease, there's no nerves in the rectum telling you when it's time to go to the bathroom. All right, giardiasis. This is a common infection of the lumen of the small intestine that's caused by a parasite. And it's often spread by contaminated food and water. It can also be spread via person-to-person contact. Now, this is obviously more common where clean and safe drinking water isn't available. Okay, so think about countries that are lacking in clean drinking water. But even rivers and lakes here, you can, here in the United States, you can catch this parasite. So symptoms of giardiasis include general discomfort in the abdomen. Maybe you have diarrhea, nausea, anorexia, weight loss, and usually you'll have a spasming of the duodenum and the jejunum. Now, oftentimes we'll do a small bowel series, a small bowel follow-through, and that's going to show us the presence of the giardiasis in the intestine. Oftentimes, though, we're going to need a stool specimen in lab to find that parasite. Kind of yucky. Make sure you're washing your hands, okay? They can treat this parasite with medications. Okay, let's look at intussusception. And remember, we also learned about this one last semester. This is that telescoping of the intestine. Usually happens in pediatric patients. And remember, the therapy includes a barium enema. When we put barium in rectally, often the pressure of the barium coming in will expand those loops of bowel again. So barium enema is a common therapy for intussusception. All right. Oh, brother. There we go. And here again is just a diagram depicting that telescoping where one piece of intestine goes into the other. And this is again the most common type of obstruction in young peds between 3 months and 6 years of age. And usually the most common type of intussusception that we see is when the ileum telescopes into the cecum. But it can occur anywhere in the small intestine or colon. Remember volvulus. So volvulus is a twisting of the intestine. And obviously this is really concerning because you're going to have a loss of blood flow, and you could, the contents in the intestines can't pass. So a volvulus is more likely to occur in men, and it's most common in adults 20 to 50 years old, but it can occur in your geriatric patients as well. A volvulus will produce an air fluid level, and you would see that in an upright abdomen. Most often, you guys, sigmoid volvulus is where we're commonly seeing the twisting. So again, in the sigmoid region of the intestine is the most common location. Here is a radiograph of a patient with a volvulus. So you can see there's a twisting or a narrowing, and then there's this huge megacolon behind it. This is all air. I mean, how uncomfortable. All right, appendicitis. So an appendicitis is an inflammation of the appendix, and we know the appendix is that little worm-like structure off of the cecum. This is considered, a pretty urgent matter. If the appendix is inflamed, you'll want to remove that before it ruptures. This is one of the most common causes of new onset abdominal pain, primarily in the right lower quadrant. Now, if we look at appendicitis, remember it's an inflamed appendix. In the olden days, it used to be diagnosed simply by clinical indications. So lab tests would show us that the patient has an elevated white blood count, which indicates an infection, fever, nausea, vomiting, right lower quadrant pain in the abdomen. Now, though, more commonly now, patients will receive a CT scan. Just to make sure they're diagnosing correctly before they take the patient into surgery. That CT scan will require oral or rectal contrast. And then for our PEDS patients, ultrasound is an option as well, so they don't have so much radiation dose. Generally, though, appendicitis is really pretty rare in pediatrics, but ultrasound is an option. All right. Diverticuli. Remember, we talked about this in the upper GI. So diverticula in and of themselves, remember it's an outpouching of the wall of the intestine. So it's a pouch that points outward. It's outside the organ. And in and of themselves, they're pretty benign. They can become pretty widespread, which you see here. These are outpouchings or diverticula. And again, they're really not, in and of themselves, they're not that concerning. What happens is fecal matter can get stuck in them. And if you remember back to the Zenker's diverticulum, when you learned the upper GI pathology, things can get trapped in these pouches. And that can cause inflammation, which leads to diverticulitis. So diverticuli or diverticula are completely fine and benign. It's when they become inflamed that the patient will have pain and even bleeding could occur. All right, so a diverticulitis is when you have an infected and inflamed diverticula. Okay? All right. And here is a great example of a double contrast BE, and all these little circles are outpouchings or diverticula. Okay? CT scans are often done to diagnose diverticulitis. Remember, think about the suffix itis. That indicates inflammation or infection. So the diverticula become inflamed or infected and lead to diverticulitis. All right. So let's talk about colon cancer. Colon cancer often starts as a polyp. And remember, a polyp is something that points into the lumen. It's the opposite of a diverticula. Colon cancer is most often found in the rectal sigmoid area, but it can occur anywhere. An air contrast barium enema or a double contrast is going to be a really sensitive test for diagnosing these polyps. And you can use a colonoscopy, and often colonoscopy is the first screening tool to look for colon cancer. So that's going to be used more often than a barium enema. Now, let's talk a little bit more about polyps. So again, polyps can be a precursor to colon cancer. That's why we're concerned about them. If they find them during a colonoscopy, they often biopsy them just to make sure that they are still benign and not malignant. A benign polyp will appear as pedunculated, meaning it has a stalk. It has like a base here, or I think of it as like a tree trunk. It looks like a tree to me. It's pedunculated. It has a stalk, and then this is the polyp. And remember, it's pointing into the lumen. A malignant polyp often is called sessile. It's got no stalk or peduncle, and it's attached by a broad base. So there'd be no stalk here present in this one. It's just the whole polyp is attached to the wall of the colon. Here is an example of polyps as seen on a BE. You can see all these little dots would indicate polyps, and again, that's concerning for colon cancer. So you want to catch polyps early and remove them or biopsy them and check for cancer. All right, apple core lesions, last but not least. An apple core lesion is it's a radiographic sign of a neoplasm. And remember, neoplasm is just a term for new growth. A neoplasm doesn't necessarily mean that it's cancerous. Obviously, we're concerned about cancer if we have a new growth, but what happens in an apple core lesion is you have something here that is narrowing the lumen of the intestine, right? So you have normal intestine. Something is here causing this narrowing, and that's often concerning for a cancer. And so you can see radiographically with barium, it kind of looks like an apple core, right? And that's what you're seeing here. Something is narrowing the lumen of the intestine. So an apple core lesion is generally, that's concerning. We're concerned about malignancy when we see that. Okay, excellent. If you have any questions, please let me know, and certainly feel free to reference my notes attached with this PowerPoint if you have more questions. Thank you.